Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled 2023 Updated AGS Beers Criteria: What's New, What's Changed, and Why. We are thrilled to have Dr. Judy Beizer as our guest who will present for us today. So before we get started, I would like to share a few quick points, some housekeeping items. So for those who may be having technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or the chat option. The CE code for this program will be provided at the end of the program. So without further ado, I'm going to go ahead and introduce our speaker. And it is with great pleasure that I get to introduce a wonderful colleague of mine, Dr. Judy Beizer. Dr. Beizer is a tenured clinical professor at St. John's University, College of Pharmacy and Health Sciences in Queens, New York. As part of her duties, she practices as a clinical pharmacist at the Stern Family Center for Rehabilitation in the Northwell Health System. At the Stern Center, she provides clinical pharmacy services for subacute rehab patients and precepts pharmacy students and residents on rotation. Dr. Beizer is a board-certified geriatric pharmacist. The floor is yours, Dr. Beizer.
Right, thank you very much. And thank you for inviting me to speak today. It's been about a year since we published the 23 updated version of the Beers criteria. And for those of you who don't know, AGS stands for the American Geriatric Society. And I'm going to focus on some of the changes, but also give you a little bit of the background of how we got to where we are today. So let's make sure all my things are working. There we go. So my disclosures, I do some editing for Lexicomp and Wolters Kluwer. I'm a consulting editor for the American Geriatric Society Geriatric Review Syllabus. And I've been a member of the expert panel for the Beers criteria for the past 4 updates. So what I'm going to talk about is really describing the history and the purpose of the AGS Beers criteria and its updates. And for those of you who aren't familiar with where it all started, we're going to talk about how we identify medications to avoid or use with caution in older adults, and then discuss the applications of the 2023 changes in clinical practice. So when we talk about the Beers criteria, it doesn't have anything to do with potent potables, as we say. Dr. Mark Beers was a geriatrician who really came up with this whole idea of potentially inappropriate medications in older adults. He was the first medical student to do a geriatrics elective at Harvard's Division of Aging. He did a fellowship at Harvard. He was on faculty at UCLA, and he was a co-editor of the Merck Manual of Geriatrics. He was a really remarkable man who unfortunately died early of complications of diabetes. But when I think about Dr. Beers, he really opened up opportunities for pharmacists to really talk about medication use, inappropriate medication use in our older patients. And so this all started back in 1991. And the original version, and he certainly didn't expect that it was going to end up being called the Beers criteria. The first version was just potentially inappropriate medication use in nursing home patients. And he got together a group of experts to kind of look at what are the drugs that we knew were problematic in older adults. It was then updated in 1997 to apply really to all older adults, not just nursing home residents. And it was adopted by CMS, the Center for Medicare and Medicaid Services, in 1999 for nursing home regulations. So any of you who are working in nursing homes, some of the drug regimen review requirements actually incorporated some of the concerns with the Beers criteria medications at that point. And in 2003, there was another update, and it was generalized to thinking about Medicare Part D was coming around, National Committee on Quality Assurance, and HEDIS sets. And then Dr. Beers passed away in 2009, and the Beers criteria kind of sat. And people were saying, well, you know, it's becoming outdated, it's not being updated. Is it still useful? There were other types of explicit criteria being published in Europe, the stop-start criteria, which I'll talk about a little bit. And then it was in about 2010, 2011 that the American Geriatric Society went to Dr. Beer's family and said, we'd like to keep the Beer's criteria alive and keep it relevant. And so we would like to incorporate it, and we will update it every 3 years, or sometimes it's 4 years. And so in 2012 was when I started getting involved with this, and where we really started looking at quality measures. In 2015, people had asked us for some drug interaction information, renal dose tables, and we also in 2015 came out with a how to use supplement article, and all these references are at the end, and also some alternatives papers. And we're going to talk more about alternatives to Beer's criteria as well. And all of this is doing with a evidence-based background, really looking at the literature. 2019, we further refined the criteria, and again in 2023, further review and updates, and that's what I'll focus on today. So how do we do this, and what is the purpose? And it really is to identify these potentially inappropriate medications, what we call PIMS, that should be avoided in older adults. And I emphasize potentially because there are going to be some times when you may really need to use these medications, but you've thought about them first and realize that there might be safer alternatives. And if you can't use them, then you have to go to some of these medications that are on the Beer's list. We're really focusing on reducing adverse drug events and drug-related problems and improving medication selection and medication use in older adults. And we'll talk about how to apply these later on. And they're essentially designed for any clinical setting except for palliative care, hospice care, because there's some of the medications on the Beer's list that you do need to use or may be appropriate in patients who are on hospice. And we use the Beer's criteria as an educational tool. I've given this talk several times. I've got another one scheduled up later this summer. It's also used as a quality tool, so you can use it in your health facility to see how are you doing as far as prescribing for your older patients, and also as a research tool. And you can find many studies that have incorporated the Beer's criteria and the various different iterations and additions in research. But one of the things when we look at explicit criteria is balancing what's a quality measure and a prescribing measure. And we know that when we recommend medications for any patient, but particularly older adults, there's a lot of gray area. It's not always a black and white yes or no. And that's why I say this is potentially inappropriate. Whereas the quality measure people, they want it, is it a good drug or a bad drug? Don't give me this gray area. And so we're always kind of balancing that. And that's something to keep in mind when you're doing any research with it or you're doing any quality assurance. So how do we do this? So the current and the 2023 team it's always been an interdisciplinary panel of experts from pharmacy, medicine, and nursing and nurse practitioners to work together. We have 12 voting members and 3 non-voting members from Pharmacy Quality Alliance and NCQA. And we divide into 4 subgroups that are multidisciplinary, and we're each assigned to different sets of drugs. And we have researchers who do an extensive literature search for us. So we get like every 6 months a stack of abstracts to go through to see which one of these studies that are affecting the medications that we're assigned to, do we want the full article pulled? So we can review it and see, is there good geriatric information in it? Is there anything in there that's going to change our current recommendations, or are there any drugs that we need to add to the Beer's criteria? And we rate the quality of evidence and the strength of recommendation. And then after each group comes up with their recommendations, as a team, we do a Delphi voting to see if we all agree or not, and going through, and we also have a public comment. So we follow the Institute of Medicine's 2011 recommendations for guideline development. So with each of the versions, we put it out there. We send it to certain organizations. We put it on the AGS website so people can make comments, and people make a lot of comments, and we review them and we take them to heart. And we do sometimes change from what we originally thought we were going to talk about. And we also present the preliminary information at the American Geriatric Society annual meeting and take any comments from there too. So it's quite extensive. It's a lot more work than I thought when I first started working on this. So the criteria are basically the main part of the criteria are the different tables and understanding what are on the tables. And so when someone says, oh, that's a Beers criteria medication, can't use it, you have to understand where it fits in the Beers criteria and why. So medications end up on the list because there are safer alternatives for older adults, or there's inadequate evidence of efficacy in older adults. And that's the important thing, is that when we're looking at the studies, is trying to make sure, did they tease out the geriatric information there? So table 2, excuse me. Table 2 or table 1 is really basically methodology. Table 2 is medications or medication classes that should be avoided in persons 65 years or older. And I'll give you examples of each of these. And table 3 are medications that should be avoided in older persons known to have specific diseases or syndromes. So these are the drug disease interactions. And table 4 are medications that should be used with caution. These are drugs that we don't have enough data or evidence at this point to put them on table 2 or 3, but they're really on our radar. And we want people, and this year we did move some medications from table 4 to table 2 because now we had more data and felt more comfortable in really telling them to be avoided, not just used with caution. Table 5 were potentially clinically important drug-drug interactions to avoid in older adults. And certainly this is not all the interactions, but things that we thought were more particularly important to think about in older adults. And table 6 are medications that should be avoided or have the dosage reduced with decreased renal function. Again, not all the drugs, but things that are used commonly or things that maybe sometimes we forget about. And interesting, people asked for those tables, but when we did a poll at one of the meetings and asked how many people actually use those tables, not too many people raised their hands, but they still wanted us to keep them there. Table 7 are drugs with strong anticholinergic properties, and you'll see that throughout tables 2, 3, and 4, we mentioned drugs, strong anticholinergics. And so if you want to know what we're talking about, you go to table 7. And these are drugs that when you look at anticholinergic burden rating scales, these are the drugs with a 3, something like diphenhydramine. And then table 8, 9, and 10 are really just letting the reader know what's been changed since the previous update. So what's been removed, what's been added, what's been modified. So if you wanted kind of the summary of the changes. So let's give an example. And I picked drugs that are, I think, particularly problematic in healthcare facilities. So skeletal muscle relaxants is an example from table 2. And I deal a lot with rehab patients, people who've had orthopedic surgeries, and people will come in the emergency room and they're like, oh, they pulled a muscle or they had some surgery, and they put them right onto a skeletal muscle relaxant. And you look at these, and there are some of them that are older medications, and they're on the Beers criteria, but the rationale, it's important to read the rationale, that the muscle relaxants typically used to treat musculoskeletal complaints are poorly tolerated by older adults because some have anticholinergic effects. There's the sedation, the increased risk of then falls and fractures, and also the effectiveness at dosage tolerated by older adults are questionable. So it's important that when you read the tables, you see the rationale or any caveats in it, see the recommendation is to avoid, the quality of evidence is moderate, and the strength of recommendation is strong. So sometimes, even though the quality of the evidence is not that strong, because some of these are older drugs and we haven't done a lot of good studies in them in the past, we still feel from our clinical judgment and our experience that this is a strong recommendation. Now, the thing that's interesting about skeletal muscle relaxants is there's 2 there that are not listed that people then think, oh, they're okay, baclofen and tizanidine. Now, baclofen and tizanidine, and I worked on this class of drugs, so I'm really familiar with what we were looking for here. They're mainly used more for spasticity, so they don't necessarily fall exactly as a skeletal muscle relaxant, but we realized they also have substantial adverse effects, but we couldn't find enough evidence to add them here. But baclofen was added to table 6 to avoid in patients with creatinine clearance less than 60 mils per minute, because there were some studies showing increase in confusion and encephalopathy in patients who had poor renal function with using baclofen. So still use caution with baclofen, still use caution with tizanidine. There are some drug interactions with it. I would have loved to add it here, but we didn't feel the evidence was strong enough. But they're still not great drugs in older patients. An example from table 3 are drugs to avoid in patients with delirium. And this is, again, a common problem in older patients in the hospital, whether in the ICU or post-op. And so these are the drugs to avoid in older adults with or at high risk of delirium, because they can make it worse. So you see here the anticholinergics, antipsychotics, benzodiazepines, corticosteroids, etc. And think about then, what could we use instead? And the anticholinergics, it depends on what you're treating. The antipsychotics, we know, have not been shown effective in preventing or treating delirium unless the person is a harm to themselves or others. And H2 antagonists, use the proton pump inhibitors. Try to avoid the opioids, thinking about good use of acetaminophen. So when we read the rationale, we see that can worsen the delirium, and then we give an example of when you might have to use them. So I just used the one for antipsychotics here. This goes much further, and when you look at the tables. To avoid the antipsychotics for behavioral problems of dementia, delirium, unless non-pharmacologic options have failed or there's a risk of harm to self or others. So we know that the antipsychotics have a black boxed warning for avoiding use in patients with dementia. But in delirium, if someone's pulling out their lines in the ICU, this might be the time when you may have to use it. So, but using it judiciously only after non-pharmacologic options have failed. And so we avoid except in situations listed under the rationale. And then again, the quality of evidence here, because we have all these different drugs listed, may depend on the drug class that we're talking about. But again, a strong recommendation. Another example that I think is also very applicable to the healthcare settings is drugs to avoid in patients with a history of falls or fractures. And so again, you look at the drugs listed here, they're all the CNS depressants. And we know why. They cause ataxia and impaired psychomotor function, syncope, additional falls. Specifically for the benzodiazepines, we used to think the shorter actings were safer, but we know they're not, that they also have the risk of falls and fractures. The antidepressants, it depends on the type. The SNRIs may actually confer a higher risk of falls. And so our rationale is, if you have to be on at least one of these, try to avoid more than one of these types of medications. And avoid unless safer alternatives are not available. Avoid the anti-epileptics unless, of course, you're treating seizures or mood disorders, it's bipolar. And the opioids to avoid except in pain management in the setting of severe acute pain. We know that opioids themselves can cause confusion, delirium, and that can also end up leading to falls and fractures. So again, you see the quality evidence depends on the class of the medication. So this is just giving you examples of how to read the tables. So let's talk about what changes were major changes for 2023. So the biggest one was really changes to aspirin and anticoagulants. And I'm going to go into these in more detail, but we felt that these were so important that we actually, this is really right from the article, was we made a separate little table here to summarize the changes. And that aspirin was moved from table 4 to 2, warfarin to avoid as initial therapy, rivaroxaban, dabigatran we'll talk about. So let's just dive into this. So aspirin had been on table 4 to use with caution in patients over the age of 70, I believe, for primary prevention. And as we were looking at this update, we were looking at some of the results from the ESPRIT trial, which was looking at primary prevention using aspirin in older adults, and really found that it was not effective for primary prevention and actually increased the risk of bleeding. And so that's where we felt strong enough to move it from table 4, use with caution, to table 2, to avoid initiating aspirin for primary prevention of cardiovascular disease, and to consider deprescribing in older adults already taking it for primary prevention. So number one, you have to know why the patient is taking it, and also explaining to patients that just, in case they read the patient version of the Beers criteria, that they don't just stop their aspirin on their own because they might have been taking it for secondary prevention. So again, the rationale was the risk of major bleeding from aspirin increases markedly in older adults, and the study suggested that lack net benefit and a potential for net harm when initiating for primary prevention. At around the same time was when the United States Preventive Services Task Force 2022 recommendations actually came out with this same recommendation. So we felt comfortable saying, and USPSTF said adults over 60 to avoid using it for primary prevention. So that's something to think about. And, there's so many different reasons patients are on aspirin, but primary prevention, avoid use in older adults. Now, warfarin. Warfarin was added for the first time, and people for years have been asking, why isn't warfarin on the Beers criteria? Warfarin's a dangerous drug. Well, warfarin is a dangerous drug no matter how old you are. So we were looking specifically again at information for older adults. And also, before, we didn't really have enough evidence on the good alternatives on the DOACs. And so once we had good evidence comparing the DOACs and the warfarin, we felt comfortable adding warfarin, because before this, if you added warfarin, then people were going to say, well, what are we going to use if we need an anticoagulant? So the recommendation is to avoid warfarin as initial therapy for treatment of venous thromboembolism or non-valvular AFib, unless alternative options, and here we're going to talk about the direct acting oral anticoagulants, unless if these alternative options are contraindicated or there's substantial barriers to their use. And we didn't really want to just come out and say like cost, but that's one of the substantial barriers that could be for older patients. So our rationale here was, compared to the DOACs, warfarin has a higher risk of bleeding and similar or lower effectiveness for treating a VTE and non-valvular AFib. Now, if you have a patient, an older patient who's been using warfarin chronically, it doesn't mean you have to take them off of it. If they've been, on it, they're reasonable, they've been well controlled with their INRs, they've had no adverse effects, they're regularly getting their INR checked, and they're okay with it, you can keep them on warfarin. So, but we're saying really for initial therapy to avoid it. And I think that's what we've been seeing in practice. I know we did a study some years ago at North Shore looking at initiation of anticoagulants and new onset AFib in older adults. And we saw that the DOACs were basically winning the race, as we say. So now what about the DOACs? So rivaroxaban had been on the use with caution. And again, we felt there was enough data to move it to table 2. And I know this caused a lot of concern, particularly from the makers of rivaroxaban. I've gotten calls and emails. But we felt that the recommendation was to avoid it for long-term treatment of non-valvular AFib or VTE in favor of safer anticoagulant alternatives. Now, this doesn't apply to the low dose of 10 milligram DVT prophylaxis in patients with orthopedic procedures. This is really for the higher doses that are used for AFib or for VTE. And it shows that and there's not great head-to-head with rivaroxaban and apixaban yet. Those studies are coming out, but it appears to have a higher risk of major bleeding and GI bleeding in older adults compared to other DOACs, particularly apixaban. Now, if you have a patient who will not be adherent to apixaban because it's a twice-a-day dosing, then yes, rivaroxaban may be appropriate for them. If there's issues sometimes with coverage, that might be appropriate. We always want our patients to be able to take their medications. And just as a reminder that all the DOACs confer a lower risk of intracranial hemorrhage than warfarin. And dabigatran had been on the table 4, the use with caution, and that was left there. There really wasn't anything new that we had to add to that. So that was the big news really with the anticoagulants. We also updated the language on the sulfonylureas. in Table 2. And the sulfonylureas had been on the Beers criteria, but particularly just focusing on the long-acting sulfonylureas. And with all the newer anti-diabetic agents out there, we decided that we really needed to look at the sulfonylureas as a whole class. And so the recommendation was changed, and the updated language was to avoid the sulfonylureas as first or second line monotherapy or an add-on therapy, unless there's substantial barriers to use of safer or more effective agents. And again, some of the substantial barriers could be financial, but, or they just, can't tolerate some of the other agents. And then we also go on to say that if a sulfonylurea is used, to choose a short-acting one, and really the only one right there now is glipizide, over the long-acting ones, like glyburide and glimepiride. And this is one that has been on the Beers criteria for a while. First, we focused just on glyburide, then we added glimepiride because we saw the studies showing increased risk of hypoglycemia. And now we updated the language even that higher risk of cardiovascular events and all-cause mortality and hypoglycemia compared to alternative agents. Again, you have somebody who's on a sulfonylurea, if you can get them onto glipizide, if you can change the agent if it's appropriate for them. But again, remembering that they're potentially inappropriate, particularly for initiation of therapy. The SGLT2 inhibitors were added to Table 4, the use with caution. And this is it took a while, I think, I thought they would be put on in 2019, but there wasn't enough data at that point. And the use with caution is really to monitor patients for the urogenital infections and for ketoacidosis. And in older patients, particularly women in the first month of treatment, they may be increased for urogenital infections. And I have seen this, and I think it's an important point that we talk with patients about, that if they've never had UTIs before and now they're getting UTIs, they need to talk with their doctor about it. Also, the increased risk of ketoacidosis has been seen in older adults. So whereas, there's great things that we can do with the SGLT2 inhibitors, not just for diabetes, I still am always cautious, particularly when I have a patient who's come in who's had a UTI with it. We updated the language for estrogen also. And really to focus on patients who are starting HRT, hormone replacement therapy, and to not initiate systemic estrogens, oral or transdermal, in older women. Because for women who are over 60, the risks are greater than the benefits. So if it's a woman who's at menopause and is having really severe symptoms, starting estrogen then is very different than starting it later. And I've in some of the earlier studies with estrogen, we're looking at starting estrogen in older women, and that doesn't even make sense, truthfully. And if you do have some older women who are still on estrogen, I've had people in their 80s still taking estrogen, I think it's something we can consider deprescribing and talking with them, and again, tapering it off, not just cold turkey and them. Now, topical vaginal estrogen is appropriate for the management of vaginal atrophy or UTI prophylaxis. So that is, again, making sure that we know what type of estrogen the patient is using. There's a lot of different things that were updated as far as language, but I wanted to just highlight a few of them here. So with the anticholinergics, there was a lot of stuff that was published over the past several years about cumulative exposure to anticholinergic and just total anticholinergic burden. And so we know that the anticholinergics, all the stuff you learned in pharmacy school, blind as a bat, red as a beet, mad as a hatter, dry as a bone. As I tell my students, all those things may in a younger person may be just a little bit annoying, but in an older person can be really bad. Urinary retention, constipation, confusion, the mad as a hatter part, but also that risk of falls and delirium. And this can be seen even with cumulative exposure and even starting in younger adults. And we need to consider the whole total anticholinergic burden during regular medication reviews, and not just those strong anticholinergics, but you want to look at some of the medications that have anticholinergic side effects that might be scored as a 1 or a 2, but if you're taking several different medications that have a 1 or a 2 and then a 3, it can add up to as if this person is on diphenhydramine. And there are various different anticholinergic scales out there that you can look, and surprising number of medications that do have slight anticholinergic effects. Furosemide, some of the H2 blockers, opioids. And so patients telling you they're having all these, dry mouth and all this stuff, and you realize it's this cumulative effect. The antipsychotics, we expanded the rationale on avoiding antipsychotics for behavioral problems, and again, to use as a last resort only if behavioral interventions have failed. And for long-term use of the proton pump inhibitors, meaning over 8 weeks, we added some risks that were added to the rationale: the risk of pneumonia, the risk of GI malignancies. We had already had in there the risk of C. diff infections, bone loss, and fractures. So more reasons to avoid the proton pump inhibitors. We did change some things in the drug interaction table, avoiding, as I talked about, multiple agents with anticholinergic effects, avoid the concurrent use of 3 or more CNS active medications, and we added the skeletal muscle relaxants to that list of medications. And we added the SSRIs to the warfarin interactions. So again, not a complete list of all the drug interactions, obviously, but things that we thought might come up more frequently in older adults. And then we decided we needed to clean up some things in the Beers criteria list, because there were medications that are hardly ever used, or actually in the US were not even being manufactured anymore. And so a subgroup of people went and looked at Part D fills in 2019 and defined low use as less than 4,000 prescription filled, which is a very small number of Medicare beneficiaries, but it took off some drugs like disopyramid, flurazepam, clemastine. So it doesn't mean that these are now good drugs. We were trying to clean things up. We also took some drugs off that were listed as discontinued by the FDA or not on the US market: methyldopa, reserpine, chlorpropamide. And we had a lot of discussion about this, because like even something like meprobamate, we hardly use it here, but we were people from other parts of the country like, oh, I still have doctors using it. I don't want to take it off the Beers criteria. They're going to think it's a good drug. So anything that was taken off, and we have that listed also, it doesn't mean we're endorsing them. It just is cleaning things up, so that you can see the things that are really important. And now I want to talk about how do we use it and how do we apply it in practice. And the 7 principles of use, this came from the 2015 accompanying article about how to use the Beers criteria. And again, the first thing is to remember that they're potentially inappropriate, not definitely. And that's why you need to read the rationale and read the recommendations for each criterion and understand why they're on the criteria and adjust your approach to those medications accordingly. Amiodarone is on the Beers criteria. It's been there because there are safer alternatives. It's not your first line to go to for atrial fibrillation, but there are some patients who do need to be on it. We know that. And so, not calling the doctor every time you see someone amiodarone, that's not always appropriate. But you want to make sure that they've tried other things first. Same thing even with digoxin. That we know it's not, the guidelines say it's not first line for heart failure, it's not first line for AFib, but occasionally you still see somebody still on digoxin. And again, make sure that they're on the appropriate dose of that too. So when you're using the criteria, it's identifying these potentially inappropriate medications, thinking about safer non-pharmacologic and pharmacologic therapies. And we are working on right now some alternatives to the Beers criteria. So that's a team of us that are looking at some of the classes and seeing what can we provide for both patient education and clinician education of alternatives to some of these agents. And think about that the criteria, just a starting point for a good process of identifying and improving medication appropriateness and safety. This is all about medication safety. We did not intend that the Beers criteria would mean that they're restricted by prior authorization or not covered by some Medicare Part D plans. We know that has occurred, but it is a way of kind of putting that little stop sign and saying, whoa, let's think first before we prescribe this medication. And the other thing that's important is that the criteria are not equally applicable to all countries because there's other drugs that are available there or things that are not available in countries. And so the other explicit criteria I mentioned earlier, the stop-start criteria, which were published in Ireland, and the third edition of that came out last summer. STOP stands for the screening tool of older persons' prescriptions, and the START is the screening tool to alert to the right treatment, so that maybe there's things that we haven't given patients that they do need, and we should be thinking about giving them. So thinking about these 7 principles is very important. So how do we apply this to health systems? You want to educate the whole team, including patients and their families. So you take what you learned today and bring it back to your pharmacy department, to your P&T committee, and think about like how you order medications in your health system. Build alerts into the CPOE system so that if it is an older person, that it reminds them, this is, potentially inappropriate medication. Here are some appropriate alternatives. If you do have any order sets, avoid putting any of the potentially inappropriate medications in those. Think about on your formulary, is there anything where you want to have restrictions or, again, cautions about how we use some of these medications in our older patients? As far as the role of pharmacists, certainly in medication reconciliation, it's a good time to see, like, is there any way we can get rid of some of these Beers criteria medication? In nursing facilities, as part of drug regimen review, this is certainly something we look at all the time, every month when we're reviewing medications. And then also think about, is this an opportunity for any research or quality improvement projects in your health system? Look at your data. Are there any low-hanging fruit that you can focus on, common PIMS? Are you still using diphenhydramine? Are people still using, amitriptyline? Are there overuse of even, the benzodiazepines and the opioids together? There's a lot of things that you can take from this, and you can use this as some of the fuel for your fire here. Again, in educating clinicians, as I say, I think of the Beers criteria as a warning light. It's a kind of a stop sign. And you see a patient on it and like, why are they taking this drug? Is it truly needed? Is it still needed? Are there safer alternatives? Are there more effective alternatives? Have we tried the alternatives? Or does this person really have the characteristics that they actually need to be on this medication? Or maybe it's increasing the risk and we got to get rid of it. And this is a good time to consider deprescribing, even just decreasing the dose or getting rid of the medication at all. Also, thinking about whether there's a prescribing cascade going on here, and assess the symptoms. Are these new symptoms you're seeing in a patient, are they due to a prescribing cascade? Whether it was a Beers medication or not, it's always important to look for that prescribing cascade. And then if you're stopping one, you need that deprescribing cascade. I was so happy that someone they were taken off of their amiodarone, and then they were actually their thyroid function normalized, and they were taken off their levothyroxine as well. That they hadn't, I hadn't thought about that initially. The other thing too is to remind people not to automatically defer to colleagues. We all say, oh, well, the cardiologist recommended it, or this one recommended it. They don't always know about the Beers criteria. They're not as, astute in geriatrics as you would think. Getting a geriatrician and getting a board certified geriatric pharmacist involved is always helpful with that too. How do we explain this to patients and caregivers? When the first updated version had come out, it was picked up on the New York Times and in their Aging Well column in the Science Times. And the one thing I was worried about is people are going to read this list and go, oh my God, I got to stop this medicine because it's on this list of potentially inappropriate drugs. So I tell people, don't stop it just because it's on the Beers criteria. You want to talk with your clinicians. You want to see, is there something safer or more effective? And this is also a good time to remind patients to learn about all the medications they're taking and to talk with the physicians about if they think they're having a side effect, or talk with their pharmacists. And the healthandaging.org is the patient-facing website from the American Geriatric Society, which has a lot of great patient education material, not just on the Beers criteria medication, but other medications, disease states in older adults, finding geriatricians and such. So a very good resource to have. So what is the take-home message? Someone said, don't let the perfect be the enemy of the good. Do the best you can and look for that low-hanging fruit. Try to fix things in your system, whether it's the inpatient or the outpatient practice. And that the AGS BRS criteria are only part of appropriate prescribing. Target your initiatives to the high prevalence, the high severity medications. Look at what's going on in your facility. And I know that other hospitals have done this. And have some shared decision-making when selecting and changing regimens. You got to talk with patients, make sure they understand why we're doing things. I love talking to patients about Benadryl, about diphenhydramine, and over-the-counter medications, and that just because it has a PM after, it doesn't mean it's a long-acting acetaminophen or whatever, and how dangerous some of these medications can be done. And and also stopping medication should be done with the same consideration as starting. You don't want any drug withdrawal side effects as well. And to think about the AGS BRS criteria really is patient-centered care. And you're really focusing on your older patient and looking at all their other comorbidities as well. And one of the things I was talking about with some students earlier today is in geriatrics, we talk about the age-friendly health systems. And I probably should have the slide in here about the 4 M's, which are mentation, mobility, medication, and what matters to the patient. Not what's the matter, but what matters to them. And then the 5th one we add in is the multimorbidity. So with medications being part of that, obviously the role of the pharmacist is very important. And so AGS criteria, patient-centered care. So there are a lot of good resources for you out there. The BRS criteria were published in the Journal of American Geriatric Society last summer. And through the AGS website, I believe you can get this without being a member. There we have a pocket card, which the print is very small. But there is the app, which you can get. We have the how to use it, the guide for patients, clinicians, and health systems and payers. That was back in 2015. A editorial on using wisely, which kind of summarizes that. And then this alternative medication list, which we're working on it now. I'm not exactly sure when it's coming out. And then again, the public education resources for patients and for caregivers. And so with that, I'm open to questions and any discussions. Thank you very much for your attention.
Thank you so much, Dr. Beizer, for this great presentation. At this time, I just want to remind the audience that if you have a question you'd like to ask Dr. Beizer, you can go ahead and use the questions tab and the questions option in Zoom, and then I can go ahead and read some of those questions live. So it looks like there are already 2 questions in there, and I'm going to just take them, from the top to the bottom. So the first question, Dr. Beizer, is, are there any best practices to use electronic medical record decision support to guide safe prescribing in elderly to decrease anticholinergic burden? DDI software, I assume that's drug-drug interaction software, only flags anticholinergics in the same class and not based on anticholinergic burden.
That's a good question. I am not sure if it's been built into any of the electronic medical records yet. I know someone years ago had talked about doing that, and was trying to take that so you could add it all up for somebody, but I don't know if that's been done yet. Good project for someone. But there are a number of different anticholinergic burden scales out there to use. But and looking at the tools too, I think one of the things that always makes me nervous, and I'm still a nervous person when it comes to the artificial intelligence stuff, is our older patients are so variable. It's not, you met one 85-year-old, you've met one 85-year-old, and they can be so very different that you can't just take the age. You have to put in so many different things to think about in that patient.
Okay, the next one we have on the list is in November of 2023, the ACC, along with the AHA, ACCP, and HRS, published guidelines for the diagnosis and management of AFib. Those guidelines make no DOAC distinction relative to the age in adult patients with AFib. Can you expand on the discrepancy between the updated AGS Beers criteria and the 2023 ACC AHA, ACCP HRS, I guess,
Yeah,
guidelines?
I know, yeah. I know, and we've gotten that question. Um, I I wasn't working on that particular subgroup, but basically on what we had at the time, we felt more comfortable. And again, we didn't really just come out and say, yes, use apixaban. I'll say that. But we were saying we felt that from the information we had, that rivaroxaban had a higher bleeding risk. And we're constantly looking at new data and as things come out, so the next version could change things. We haven't been doing like any kind of update in between the full updates, like any like corrections or anything. But that's really, it's what you were working at the time. Because remember, we published this, it was online last April, and then came out in the print publication in the summer. So I know there's a lot of controversy with that. But if and the other thing too is essays, even when you look and when we were looking at our AFib project that we did some years ago, apixaban seemed to be much more popular of an agent than rivaroxaban. But that was just, in one hospital.
The next question we have is, when should we be on the lookout for alternative publications?
Well, our timeline is, I think, to get it finalized by the fall. Then it has to go through the AGS board and clinical practice committee, and then it has to get accepted by the Journal American Geriatric Society. So I'm never one for predicting good things on timing, but maybe 6 months or so. I've been my section was what I'm working on. I'm working on some of the GI meds, and that was updated just recently. So we're working on that.
Okay, next. I noticed that Eliquis has not been advertised on the nightly news recently. Would this be due to the Beers criteria?
That doesn't make sense. I don't
Yeah.
No, because it's Xarelto, the brand Xarelto that was the one that was on the Beers criteria, not Eliquis. I'm not sure what they meant by that. But I know that some of them are starting to go generic. And the other thing too is, remember that these are some of the drugs that are on the list of 10 drugs that Medicare is going to be able to negotiate with the pharmaceutical manufacturers for lower prices. So that will actually be interesting to see how that changes things too.
Okay. If someone has PAD but is on Plavix and aspirin, is it still recommended they stop the aspirin based on the new Beers criteria?
No. We're talking about primary prevention. So someone has no history of cardiac disease, and in the old days, like, well, you're old, like take an aspirin a day, it'll prevent anything, right? That's what we're talking about. If you have a condition that needs, aspirin, that's, basically you already have PAD, so it's like a secondary prevention.
We have lots of great questions in the chat box, in the answer box. So next one, any thoughts about chronic medication treatment for patients older than 95? Meaning, do we really need to continue statins and other agents that are not urgent emergent treatment?
I laugh because I have that question all the time. My 100-year-old is still on their statin. And that's where, again, you go to the shared decision making. And again, that your 95-year-old may be very different. There's different 95-year-olds. And so what's important to them? And discussing it. If they're having side effects, if it's a burden to be taking these medications, yeah, we have that discussion. Why were they put out in the first place? What are their other comorbidities, and such? So you can't just say someone over 95, you could stop their statin. There are times I think that, but I also know that there's a lot of shades of gray here with it. Yeah. But it's a good question, and it's a discussion to have with patients, particularly also the end of life. And that gets into time to benefit. That's a whole nother talk. And thinking about, if I start a medication, if I'm starting a medication now, will my patient live long enough to see the full benefit of it? That's really the question if you're starting a medication. The continuing is a tougher one.
Next question. When a pharmacist in any setting has recommendations to adjust medications to the patient, any insight on how to get these recommendations across to the patient's provider, as older adults may often also have a complex network of providers caring for them?
Right. And that's where sometimes if they have a geriatrician who's kind of overseeing their team of specialists, that's a good person to focus on, or their primary care person, hopefully, who knows where all these different prescriptions are coming from. But I think again, it's explaining to clinicians about the Beers criteria. As I said, I was shocked. A friend of mine who I thought of as a very great, like, PCP, family physician type thing, and he had never heard of the Beers criteria when I started working on it. And so I always send him the regular updates. And there's a guy who I thought of as a good doctor. He just didn't know. So it's explaining to patients and clinicians and prescribers, this is the reason why they're potentially inappropriate. And this is, again, when we have alternatives, thinking, does this patient need to be on this medication or continue the medication, and providing the evidence, and we provide a lot of references in the Beers criteria as well, to help people understand why these drugs are there. It's not just a bunch of talking heads sitting around the table going, good drug, bad drug, good drug, bad drug. We spend a lot of time on the literature.
Next question we have is, with regards to the antiarrhythmic medications like amiodarone, why is this avoided in older adults? It is usually reserved for older adults due to the long-term effects, liver, lung, thyroid, rather than used in younger adults.
Because of the side effects again, and all the ones that you just mentioned. Just because they're older doesn't mean they're not going to get those side effects, and they're safer alternatives. So, and drug interactions and such too. But that's really why it's been on the list since I've been working on it. Yeah.
Okay. Any guidelines for vaccines after 90?
They should get the vaccines. Anyone over 65. I mean, they're particularly, flu, COVID. The RSV is a plus minus. I've been letting people decide on that. But older people should get their vaccines. Shingle, if they haven't had shingles vaccine by then, they should get it.
Next question.
And if they haven't had a pneumonia vaccine by then, they should have one. Yeah.
Okay, the next one we have is, how would approach using the Beers criteria critical care ICU, since many sedating medications like benzos are constantly used?
Yeah, that's a tough one. And I just recently was on a panel. We were talking about delirium and delirium risk factors and such. And that's one where, sometimes you do have to use them again because their patients may be pulling out their lines or whatever. So you want to think about all the things you can do, even non-pharmacologically, to make sure that the person is as oriented as they can. Make sure they have their hearing aids. So they make sure if they wear glasses and they're awake enough that they have their glasses. That you're taking care of all the other stuff that could lead to delirium. Are they in urinary retention? Are they constipated? Are they in pain? And how do you treat all these other things before just immediately giving them a benzodiazepine or an antipsychotic? But there are times when you have to use them, and you want to use them judiciously and in as small a dose as possible. And we know that. So, as I said, again, end of life is a different situation when we do often have to use the benzodiazepines or antipsychotics, but you don't want to knock somebody out so much that they can't have any meaningful relationship with their loved ones at the end of life. And so it's the same thing really in the ICU. It's very tough. But all these non-pharmacologic things, the environment, and if you can have someone, a family member with them as much as you can, so that helps to orient them as well too. And these are all the things that in geriatric units and hospitals, they try to use we use we use more melatonin than anything for as a hypnotic. Does it work or not? It depends on the patient. There have been studies of suvorexant, and also one that I looked at when I was talking about delirium, and all the alternatives you can use instead of benzodiazepines for sleep.
Next question we have is, would Beers criteria segment based on age groups like 65 to 75, 75 to 85, or 85 plus? Does Beers have any kind of data like that?
That's a good question, and it's hard enough when we're looking at the literature to just segue, less than 65 and over 65, and so I think again it's using your clinical judgment, because we don't have that. And there's so little data that's really looking at each of those, like we call it the young old, the old, the very old. So again, it's looking at your patient particularly. Does every 65-year-old now, I'm 66, do I avoid all the Beers drugs? Well, I try to, but I don't think I'd fall into necessarily right now into the category that I'm at a high risk for them, but it's stuff I think about. And I think as we get older, where does that frailty come in, where it really makes a difference? Is it 75? Is it 80? And that's, again, everyone is individual. And so you're really that patient-centered care. One 85-year-old is one 85-year-old. I have a lady who's 104 years old in our synagogue, and she walks to synagogue upright, in heels, totally with it. And, she's amazing. And then I have people who are, in their 60s in the nursing home who are a wreck physically. So getting over our ageism kind of thing is very important too, I think, with all this.
And I think we have time for maybe one last question that was put into the box. Methyl-dopa being safe in pregnancy. Why is it being discontinued for childbearing patients?
This is just what I mean, we saw this when we were looking. I wasn't on the team that looked at what was being discontinued. It's not so much you can't get it. It's like it's not considered like a manufactured. You can't find any. I don't know for pregnancy. Obviously, it's not my area. So I don't know why they did that. I think they use other things now too in pregnancy. But
Great. So I don't see any other questions in the box. I do want to say thank you so much, Dr. Beizer, again, for providing today's webinar and really going through everyone's questions. And I will now provide the CE codes for today's session. The CE codes will also